Hey everybody, Doc Schmidt here. I'm a GI doctor who likes to make educational and comedic videos. This is going to be a Q&A video where I answer questions from you guys. I got so many responses. I think I got close to 300, so thank you so much for that. I picked the top 5 comments based on the thumbs up that each comment got, and then I added a bonus question at the end, so stay tuned for that. I'll definitely plan to do more Q&A videos in the future too, so feel free to put more questions in the comments if you'd like. Let's go! Question number 1 from McLovin, of course. How do I plan out my videos? Do I script them? Do I write down an idea immediately? How much time do I spend on everything? What's my routine? I definitely spent some time talking about this in my video yesterday as well, where I talk about how I went viral over the past 10 months, so feel free to check that out. You can click that up there to go to that video. But I'll talk about it here right now as well. The long and the short of it is I keep a running list of video ideas in the Notes app on my iPhone. So I probably have 50 ideas right now. That way when I have some free time, I can look at that note and I can kind of plan out a video from there. So unless I'm really excited about a video, I don't usually come up with the idea and write the whole script out in one sitting. But I do write a full script out for the vast majority of my videos. Part of the reason I have to write a full script out is because it makes me much more efficient. Because a lot of the times I'm trying to keep a video to 60 seconds or less. So if you're ad-libbing, it's really hard to do. So I have to be very precise. I also have to be able to edit out things. So sometimes I have to write kind of a longer version of a phrase and a shorter version of a phrase, just in case I'm right at the 61 second, 62 second mark and I need to cut out 1 or 2 seconds. The most time-consuming part of doing a video is definitely coming up with the idea and writing it all down, I would say. So I would say coming up with the idea, writing out the script, that might take 20 to 40 minutes, depending on if I have a good idea ready in the chamber, so to speak. Filming the video, assuming it's like a 1-minute video, like my YouTube Shorts or my TikToks, takes less than 10 minutes. I can usually edit them together in about 15, 20 minutes, depending on if I'm having to really work to cut out that last final second to get it under 60 seconds. And then honestly, adding subtitles, which I don't do for all my YouTube videos, but I do for all my TikToks, that can be one of the most time-consuming parts. Obviously, TikTok has the ability to put in captions and YouTube does too, but I think there can be a comedic element to the caption, so I like to do it kind of manually myself sometimes, especially for my comedy skits. Overall, each day I probably spend about an hour working on video stuff, I would say. Some days it's more. If I'm less busy, I might spend 2 to 3 hours on it so that I can not have to spend as much time on days when I'm busier or when I'm on call. It's a lot of fun, but it's definitely a lot of work and can be time consuming. Thanks for the question. Time for question 2. This one's from DocRinger10. This is a question about my interactions with surgery as a GI doctor. How do I handle disagreements with the surgery side? This person references a personal experience they had where there was a disagreement over whether the gallbladder needed to be removed or whether the gallbladder was the issue in the patient's presentation. Surprisingly, or unsurprisingly, it's actually pretty common that 2 specialties will disagree. It's not always GI and surgery. Sometimes it can be GI and medicine. Sometimes it can be nephrology and cardiology. That's a very classic disagreement that people make jokes about all the time, based on the fact that specialties have their own kind of way of thinking about things because they were trained with regards to their organ system or their field in general. So the long and the short of it is it's all about communication. In the hospital, unfortunately, a lot of times we actually don't directly communicate with each other. We might communicate through the primary team, which is going to be a hospitalist or internal medicine team, or we might just put our recommendations in our notes. And sometimes those notes do have contradictory recommendations, which can be really frustrating for the primary team. For GI and surgery, more specific to this question, the gallbladder is often a point of contention. We often disagree about whether a patient should get an EGD, should get a colonoscopy versus should go to surgery. So it can be even more convoluted in a teaching hospital like where I work, because there's interns, there's residents, there's attendings, there's fellows. So not everybody has the same level of knowledge and not everyone fully knows the plan. Usually the interns are tasked with communicating things, but obviously they're the least trained, so they can get a little bit confused sometimes. Patients aren't in danger because if there's something like a disagreement that doesn't quite make sense to me, then I'll just ask the intern if I can talk to the resident or I can talk to the fellow or the attending. And it works the same on my side too. If I'm saying something and the surgery team doesn't really like it, they might ask to talk to my attending because my attending is the one that's ultimately in charge and has the full plan. It's all about doing what's best for the patient, and often that takes compromise and a lot of discussion. Question 3 from Hank. This is a fun one. How often do I get patients who accidentally slipped or fell on a long, hard object? This question is getting at rectal foreign bodies, where patients either intentionally or accidentally will put objects up their butt, and they can get stuck sometimes. Now, believe it or not, this actually hasn't happened to me as often as you might think. I've been a GI fellow for about 14 months, and I've only personally encountered 2 cases of this, so I'll go through them real quick because they're kind of interesting. One of them was not the patient's fault. For real. We actually do a test called anorectal manometry that involves a balloon that we actually insert into the anus. And the reason we do this is so that we can measure pressures. The patient pretends to have a bowel movement, squeezes down on the balloon, bears down, and we can actually measure how much pressure they're exerting. It gives us information on whether you might benefit from specific therapies. But in this one patient, this very unlucky patient, the balloon actually popped, which based on talking to other GI doctors, essentially never happens. And the balloon got stuck inside the rectum. It was too far in to reach for the nurse to pull out. Luckily, this had a very happy ending. There's nothing concerning about a soft balloon being stuck in your rectum. So in that case, it was just a matter of time of waiting a little bit and the patient passed the balloon with a bowel movement. The other time I was on call on a weekend and I got woken up at about 6 a.m., so not crazy early at least, with a call from an outside hospital saying that there was a patient who had put a vibrator up their rectum and it was stuck and it was still on. This was the second time this had happened to this poor patient. And they asked if they could transfer the patient so that I could do a scope and take the thing out of there. But actually we didn't, because this is usually a surgical problem for a couple of reasons. One, if it's too large or it's too stuck or too far up, we can't safely reach it and remove it. The other thing that's interesting that I didn't realize is if the vibrator is still on, if we grab it with the scope with our snare, which is kind of like a lasso, and pull it into the scope, the repeated vibration can actually break the camera of the scope. So usually it makes sense for the surgeons to try to remove it, because if we go in and we try to remove it, especially after hours, there's a good chance we won't be able to get to it and we'll have to call the surgeons in anyway. So in that case, I didn't actually have to go in. I just asked them to call the surgeons, and the surgeons thankfully removed the object. Question 4 is from Rachel Allison. What are the pros and cons of using those little cameras that patients swallow? This is called a capsule endoscopy. And she asks if it's a legitimate alternative to the classic scopes. It's not exactly an alternative. It's sort of an additive therapy. You may or may not know that an EGD and a colonoscopy, EGD is a scope from above and a colonoscopy is a scope from below, they actually don't cover the whole GI tract. There's part of the intestines that neither one of those scope reaches, the jejunum and part of the ileum, which are in the small intestine. So if we're looking for a bleed, for example, we know a patient's having blood in their stool, and we do an EGD, we don't see any blood. We do a colonoscopy and we see blood coming down from below, but we can't find the source, and we know that the source must be higher than where the colonoscopy can reach. That would be one indication for a capsule endoscopy, because you can swallow this pill, which is a little camera, and it goes obviously through your entire GI tract until you eventually poop it out, and it's recording the whole way down. So we can see into the jejunum and we can see into the ileum, those parts that our scopes couldn't reach, and find out if there's bleeding there. So why don't we use this all the time? Because you can't treat the bleeding with the pill. If someone didn't want an EGD, for example, but they wanted to know where the bleeding was coming from, we could have them swallow the pill camera, and it would go into their stomach, and it might see a bleeding ulcer in their stomach, but we couldn't do anything about that. We would still have to do an EGD to go in and burn the area, put a clip in the area, something like that, to stop the bleeding. Why do we ever do the capsule endoscopy? For a couple reasons, but one, there are some very specialized scope procedures that can reach farther into the jejunum than a typical EGD. That's called a push enteroscopy or a double balloon enteroscopy. And some of those are really specialized, so your GI doctor might not do those or might not be trained in those procedures, but we would want to know that the bleeding is occurring there before we refer you to another hospital where that procedure can be done. Those procedures are also a little bit higher risk, so you want to know that there's some bleeding going on that those procedures will be able to treat before you go through the trouble of doing the procedure. So the short answer is you only do the capsule endoscopy in unique situations, because usually the scopes, the upper endoscopy or the lower endoscopy, the colonoscopy, are sufficient. Question 5 was the most popular one. This is a two-parter. What made me want to work in the GI department? I get that question all the time. And what department would I be in if I wasn't in a GI department? So why did I pick GI? Because it's a specialty, first of all. I didn't want to do general medicine. I wanted to specialize in kind of one area of the body to be more of an expert. But even though it is a specialty, it's still a broad specialty, in that there's a lot of different things within the specialty that you have to learn. The esophagus, there's the stomach, there's the intestines, there's the liver, there's the pancreas, and the biliary system. And these all have very unique pathologies associated with them. I really like the physiology and the pathology of the GI tract, just learning how we break down things, how we digest things, how the liver works. The liver has so many roles, it's amazing. That's why they call it the liver, I think, because you really need it to live. I might have made that up. I also like that GI is diverse in other ways. You see people in the clinic and in the hospital. You have emergencies, but you also have chronic care like IBD, inflammatory bowel disease, or IBS. If I wasn't doing GI, it's hard to say for sure, but I would say honestly I probably would go back to doing general internal medicine. I'd have to think about whether that would be in the clinic doing primary care, like whenever you have just like a cough or cold, you would go see that doctor, versus being a hospitalist, which is like a primary care doctor that only sees patients in the hospital when they're acutely ill. Now, I wanted to throw in one final bonus question. I was just looking through, and this question caught my eye. How do you deal with patients you suspect are lying to you? It's a tough situation because you don't want to accuse patients of lying, because a lot of times patients have been through a lot with the medical community. Doctors can be difficult to deal with, and patients, unfortunately, sometimes aren't taken seriously. So you never want to assume a patient's lying, especially the first time you talk with them. You always want to give them the benefit of the doubt, even if what they're saying doesn't quite add up. Just because a patient says something that doesn't make sense to a doctor doesn't mean that they're lying. It might just mean they don't fully understand what's going on. Or if they're referring to a prior situation where they say a doctor did one thing in response to them saying one thing, there's often things that get lost in translation. So you don't want to assume either the previous doctor or the patient is lying. But I did have one situation where a patient lied to me. Patient was in the ER, had Crohn's disease, and was reporting really significant abdominal pain. He said that his daughter was getting married, and he just needed some pain meds and some antibiotics and needed to get out of there. I was like, well, we can't just do that. We've never seen you before. We had no records in the system of this patient because he had moved recently from Georgia. So I said, why don't we admit you to the hospital? We can watch you. We can check some labs, check some imaging. He was like, no, I got to prep for this wedding. It's in a couple days. So I said, okay, we'll give you antibiotics, but we can't give you steroids until we know if you have an infection. So we need to check you for a stool test. He said, I don't have time to leave a stool sample now. Can I come back later? I said, sure, that's fine. The ER gave him a little bit of pain medicine, some narcotics, and sent him on his way. He was supposed to see me in clinic 3 days later. The wedding, I think, was 4 days away. The day of the clinic visit came, and he called my clinic asking for more narcotics. You don't usually use narcotics to treat Crohn's disease for a few reasons, one of which is that narcotics can actually make Crohn's pain worse. So I said, no, we can't just give you more narcotics over the phone. We need to see you in clinic later today. Patient didn't show up to clinic. Then I went in and I reviewed his chart a little bit more in depth, and I was able to find in Care Everywhere, which is a way that we can see records from other hospitals that aren't in our same hospital system. I was able to see an ER visit from just about 2 weeks ago. And in that visit, the ER doctor put in their note that they recognized this patient, that he had told a very similar story a year prior, saying that his son was getting married and that he needed pain medications urgently. He may have had Crohn's, but it seems like unfortunately there was some level of lying in this situation, just trying to get more narcotics. In terms of how I handled it, I never really saw the patient again, but hopefully the patient gets the help he needs. Sorry to end on a little bit of a down note, but thank you so much for the questions. If you have any additional questions that I didn't answer, which I'm sure you do, because I unfortunately had to skip over a lot because you guys responded so well to my post, feel free to comment below. Thank you for watching. Please like and subscribe, and I'll see you guys next time.